am going to introduce our next speaker who's coming to us from afar. Katleho I'm so sorry if I get this wrong, Limakatso holds a Ph.D. in anesthesia, Master's of Science in Pain, a Ph.D. diploma in Interdisciplinary Pain Management, and a Bachelor's of Science honors in physiotherapy. He has a special interest in chronic post-surgical pain syndromes, particularly phantom limb pain in people with amputations. His research combines experimental and clinical methods to develop and test new interventions for managing phantom limb pain. He is recognized as an emerging researcher in phantom limb pain, serving as a regular speaker at national and international conferences. So, I'm on TV too. Welcome. We're looking forward to your talk.
Thank you so much for the invitation. I would have loved to be there in person, but unfortunately, due to unforeseen circumstances, I couldn't make it. Nevertheless, I'm still excited to be presenting today. So I'm going to be presenting on an interdisciplinary perspective on managing phantom limb pain. So throughout this presentation, I'll be giving you updates on what has been happening recently in the phantom limb research space. So the outline of my research is fairly straightforward today. We will first start by having an in-depth background on phantom limb pain, focusing specifically on the physical pattern of phantom limb pain. Secondly, we will go through the impact of phantom limb pain in order for us to understand how big of a problem this condition is and how it affects people's lives. Secondly, we'll have a look at some practical consideration for the effective management of phantom limb pain. We'll start first by having a look at underlying mechanisms. So it is worth mentioning that not all phantom limb pain presents the same. And the presentation of phantom limb pain is strongly driven by underlying mechanisms at a particular time point. While peripheral mechanisms may be a strong contributor of pain in some patients, in others, central mechanisms may have an important role. So having looked at the underlying mechanisms, then we will move forward and discuss mechanisms-based treatment options, where we will compare pharmacological treatments versus effective non-pharmacological treatments for pain. And then we will have a look at outcomes associated with phantom limb pain, because like other types of pain, phantom limb pain is affected by several biopsychosocial factors. So we will look into this and how we potentially target them to provide a holistic treatment. And then lastly, we will have a look at patient preferences as well as their role in ensuring patient-centered care that yields beneficial outcomes. So let's get started on some background on phantom limb pain. Phantom limb pain is post-amputation syndrome characterized by painful sensations in the recent part of the amputated limb. These sensations are often described as squeezing, stabbing, cramping, shooting or shocking, and burning type of pain. In some cases, the pain can be felt as a result of a limb being stuck in an abnormal anatomical position. The onset of phantom limb pain can be immediate, whereas in some cases it may be months or even years after a limb has been amputated. So recently we found conflicting reports in the literature concerning the prevalence estimates of phantom limb pain. While one study reported a low prevalence estimate of 7%, another study reported a markedly higher prevalence of 90%, with many other studies reporting estimates within this range. In consideration of these conflicting findings, My team and I in Cape Town at the time conducted a systematic review and meta-analysis to estimate the prevalence of phantom limb pain in people with limb amputations. In that review, we included and analyzed data from 39 studies conducted in 15 countries highlighted on this map here. So as we can see, we had a fair representation of studies conducted in North America, some parts of Europe, South America, as well as Asia. But most notably, there were no studies at the time that had been conducted in Africa. But we've since conducted prevalence studies in some regions of the continent, and they seem to be comparable with the prevalence estimates that we have found elsewhere. So the pooling of all these 39 studies in a meta-analysis yielded a prevalence estimate of 62.4%, thus indicating that phantom limb pain is common in people with limb amputations. So as far as these results stand, they indicate that roughly 6 or between 6 and 7 people out of 10 will experience phantom limb pain. So these findings are supported by the findings of a similar review that revealed a lifetime prevalence of up to 87% after amputation. Altogether, this indicates that 9 out of 10 people with limb amputations will experience phantom limb pain in their lifetime. This is a very high statistic, and healthcare professionals ought to be aware of the high rates of phantom limb pain and implement strategies aimed at preventing its onset perioperatively and reducing its severity post-operatively. So now that we know that phantom limb pain is common, it is a big problem in terms of prevalence estimates, let's have a look at some of the key factors concerning its impact in people with limb amputations. So there is a significant amount of evidence indicating that phantom limb pain is debilitating and that it has a negative impact on the patient's psychological well-being. We know that depressive symptoms are 3 times more likely to be present in individuals with phantom limb pain than in those without phantom limb pain. In addition, we know that individuals with phantom limb pain have been shown to have a stronger sympathetic stress reaction, thus making it difficult to cope with day-to-day stresses, and this may have an effect on pain as well. Secondly, we know that people with phantom limb pain have higher rates of catastrophizing, particularly in categories of helplessness and rumination. So for people with phantom limb pain, sometimes they feel helpless without knowing what to do with the condition or where to seek help. We've also noted higher rates of substance abuse, such as alcoholism, as well as activity avoidance in this patient group. Thirdly, we've noted that phantom limb pain tends to significantly interfere with sleep than in those without phantom limb pain, and it also has a negative impact on function, particularly when it comes to the ability of using assistive devices such as a prosthetic limb. So phantom limb pain can become a hindrance in terms of the rehabilitation plan and the attempt to restore patients to the highest level of functioning during rehab. Lastly, phantom limb pain has an impact on the patient's quality of life in that it impacts the patient's ability to participate in activities of daily living, such as work. So overall, this evidence indicates that phantom limb pain is a big problem. Not only is it common, but it has dire consequences for those who experience it. As a result, we as clinicians need to be aware of this and implement strategies for effective prevention and management. So let's have a look at some of the strategies that we could potentially employ for the effective management of phantom limb pain. So the first one is identifying the underlying mechanisms, because this will inform the type of treatment that you will employ in your rehabilitation journey. Because I've already mentioned that not all phantom limb pain is the same. So let's look at some classifications here. So, as mentioned earlier, phantom limb pain is often broadly categorized as one term or under one umbrella term, without accounting for the diverse factors that contribute to variations in its clinical presentation. Some of these factors that may result in variations in clinical presentation includes the indication for amputation. We are starting to see some differences between patients who were amputated as a result of trauma compared to those who were amputated as a result of having long-lasting disease complications such as diabetes. Secondly, we have exposure to phantom limb pain predictors. In a recent systematic review that we conducted, persisting pre-amputation pain was identified as an important predictor of phantom limb pain. And we are starting to see differences between patients who were exposed to having persisting pre-amputation pain versus those who were otherwise healthy and then were amputated, mainly because of trauma. Thirdly, duration since the onset of pain seems to play an important role, especially when it comes to informing us about the peripheral nature or the central nature of the pain that the patient might be experiencing. So far, what we have seen is patients who experience an early onset of pain after amputation tend to benefit from treatments that target the periphery, whereas patients with chronic phantom limb pain tend to benefit from treatments that target central mechanisms. So the duration of pain can help inform us about the targets for treatment. Altogether, this evidence indicates that the clinical presentation of phantom limb pain can vary depending on different combination of these factors. And this suggests that different targets for treatment exists. It could be in the periphery, it could be centrally. And also, this indicates that the efficacy of treatment is dependent on its ability to effectively target the underlying mechanisms at a specific time point. Therefore, it is important to ascertain which mechanisms might be strongly contributing to the patient's pain presentation, because that informs the treatment strategy that we will employ in our rehabilitation. So let's start first by having a look at peripheral mechanisms. A study by Vessel et al. Provides a compelling argument about the peripheral origin of phantom limb pain. This study was published almost a decade ago, but it's still relevant to this day. So in this study, the authors argue that phantom limb pain is primarily a bottom-up process due to accelerated input generated ectopically in the dorsal root ganglia of the nerve that once innervated the phantom limb. And their conclusion is based on the consistent evidence of ectopic firing at the dorsal root ganglia. And also, this conclusion is based on the rapid pain relief following an intraforaminal epidural block. So essentially what they did in this study, they monitored the activity in the dorsal root ganglia, and then they provided intraforaminal epidural blocks. I believe they used lidocaine, and that showed rapid and visible pain reduction. And based on these findings, they concluded that pain may be driven by peripheral mechanisms. Another study focusing on peripheral mechanisms provides an argument in favor of a neuroma as an important driver of phantom limb pain. In this study, the authors support that phantom limb pain is still a bottom-up process due to exaggerated input, but not in the dorsal root ganglia, as Vess and colleagues alluded, but rather in the neuroma of a nerve that used to innervate the amputated limb. And their conclusion is based on the consistent evidence of ectopic firing at the neuroma, as well as a positive Tinel's test described as pain elicited by tapping or applying pressure on the neuroma. So a positive Tinel's test is consistent with the characteristics of nerve conduction, in that an irritation of the proximal part of the nerve elicits symptoms felt in the distal parts of the nerve. For example, if the nerve was to be irritated more proximally, symptoms would also be felt more distally, though it was irritated more proximally. In individuals with limbs, this may be described as neuropathic pain. However, this can be experienced as phantom limb pain in individuals without limbs. And another evidence that can support the role of a neuroma in phantom limb pain is the pain that is reduced by anesthetizing the actual neuroma. There are several studies confirming this, so a neuroma can be an important driver of phantom limb pain. So let's move on to important central mechanisms. So central theory suggests that phantom limb pain is driven by maladaptive reorganization in cortical areas that subserve movement and sensations. This reorganization is characterized by the expansion of adjacent cortical areas into an area that innervated the amputated limb. It is thought that this type of reorganization occurs as a result of a loss of sensory and motor input from the amputated limb, and that perhaps restoring it would alleviate pain. This conclusion by early authors is based on an observed positive correlation between cortical reorganization and pain severity, in that the greater the extent of reorganization, the more severe the pain. The conclusion is also based on an observed positive correlation between normalization of cortical reorganization and pain reduction. And this is a theory on which most of the treatments that we use today are based, rather. However, we found it interesting that contrary to this theory, McKean et al. Argue that phantom limb pain is associated with reserved structure and function in the cortical areas that previously innervated the phantom limb. So they suggest that cortical remapping does occur, but it occurs only temporarily, and homeostatic mechanisms maintain the stability and the preservation of the deprived area. So this is a total opposite of what Professor Floor and others have presented earlier in terms of the underlying mechanisms of phantom limb pain. So as we close this section, let's have a look at some key consideration. In terms of peripheral mechanisms, we know that heightened nociceptive activity, whether from a dorsal root ganglia or neuroma, is seen in amputees with post-amputation pain. Not all of them experience phantom limb pain. The same applies for cortical mechanisms. whether there's cortical reorganization or a preserved cortical representation. Not all patients who have these features experience phantom limb pain. And in the same way, we know that all amputees experience sensory and motor deprivation as a result of losing a limb, but still, not all of them experience phantom limb pain. Altogether, this suggests that the mechanisms that have been presented may not be necessary or sufficient for triggering phantom limb pain. And more work still needs to be done here in order for us to understand exactly what underpins this condition. Nevertheless, there is some consensus that peripheral mechanisms may be responsible for triggering the early onset of phantom limb pain, and that central mechanisms may play an important role in maintaining pain. So knowing this is important as it informs us about the treatment that we will use with our patient. So now that we know about underlying mechanisms, let's have a look at some of the treatment options that we have. The current guidelines recommend the use of pharmacological and non-pharmacological interventions for managing chronic pain. In this section, we will review the evidence on pharmacological treatments as well as non-pharmacological treatments for phantom limb pain. Starting off with pharmacology, the latest Cochrane review of pharmacological treatments for phantom limb pain identified 7 treatments under 5 treatment classes. The first one were opioids and morphine specifically, administered intravenously or perorally. So in this review, morphine showed short-term efficacy, but with considerable adverse side effects such as constipation, sedation, tiredness, dizziness, vertigo, and respiratory problems. Botulinum neurotoxins, specifically neurotoxin A, showed no efficacy at all. Whereas NMDA receptor antagonists such as ketamine and memantine showed, rather dextromethorphan showed some efficacy, but with serious side effects noted for ketamine, such as loss of consciousness, sedation, hallucination, hearing and position impairment, and insobriety. Memantine was shown not to be effective at all. Anticonvulsants such as gabapentin showed conflicting results and with adverse such effects such as dizziness, headache, and nausea. Lastly, antidepressants such as amitriptyline showed no efficacy at all. So this is quite interesting because in clinical practice, most of these treatments here are used routinely and they form part of the perioperative care of people with phantom limb pain who experience it after amputation. But we find it quite interesting here that they're either not effective or they are effective with considerable side effects. So this may present a problem for clinical practice. Therefore, more research needs to be done in this area. The authors of this review concluded that the evidence is so far inconclusive. Therefore, larger and more rigorous randomized controlled trials are needed to better inform us about the role of pharmacological treatments for reducing phantom limb pain. Since the publication of this review, several other randomized controlled trials has been published. Therefore, it is necessary for us to update this work. My recommendation is an analysis of individual patient data may be necessary to inform us about patient types that are likely to benefit from treatments that show some efficacy and limited side effects. So concerning pharmacological treatments, more work still needs to be done, because overall, some efficacy that's shown by this treatment is overshadowed by their considerable adverse side effects. And it is due to this reason that non-pharmacological treatments may be preferred due to their efficacy and safety. So with that said, let's move swiftly towards non-pharmacological treatment for phantom limb pain. So given the weak evidence for pharmacological treatments and the difficulty in conducting meta-analyses for non-pharma treatments, consensus on the first management of phantom limb pain had to be reached using alternative methods. So a couple of years ago, we conducted this study with the aim of generating expert consensus on the effective management or treatments for phantom limb pain. At the beginning of this study, 37 treatments were proposed by experts. So this just shows the variety of treatments that we have for phantom limb pain. And at the end of that study, 7 treatments were highly rated as being effective for reducing phantom limb pain, 6 of which are non-pharmacological treatments. The highest level of consensus was shown for mirror therapy, then graded motor imagery, of which mirror therapy is a component, cognitive behavioral therapy, which is a psychological treatment, and then using a functional prosthesis, virtual reality training, and sensory discrimination training. So these treatments were endorsed as being effective for reducing phantom limb pain at the time. So we found it interesting that all of these treatments, except for cognitive behavioral therapy, focus on sensory or motor retraining of the phantom limb. And so far, we've seen that any treatment that focuses on retraining these components seems to show better efficacy compared to other treatments that may have different targets. So let's start first with mirror therapy. A systematic review investigating the effectiveness of mirror therapy was recently published. In that review, the results showed that mirror therapy was more effective than other control treatments overall. And early studies proposed that mirror visual feedback is a therapeutic component of mirror therapy. However, a systematic review found no difference in pain outcomes between studies comparing mirror therapy versus covered mirror therapy, in which visual feedback was eliminated. So these results are corroborated by a meta-analysis showing no significant difference between the two groups. So altogether, this finding suggests that phantom motor execution, or moving the phantom limb, is more important and powerful instead of mirror visual feedback. So this has helped us to develop treatments that are more targeted towards retraining the motor execution of the phantom limb instead of focusing on mirror visual feedback, which seems to be not so much important in the alleviation of phantom limb pain. So seeing that mirror therapy is the gold standard for reducing phantom limb pain, we were more interested in evaluating how mirror therapy is being applied across the literature. So we recently conducted a scoping review evaluating this. And in this review, we compared the application of mirror therapy in studies with clinically significant pain reductions versus those showing no effect at all. So several treatment features were similar across both studies, those with and without significant pain reductions. However, we noted some differences. So the first difference that we noted is is that adherence to treatment protocol is essential for achieving significant pain outcomes, in that studies that showed poor adherence to treatment did not show or report positive outcomes. The second important treatment feature here is phantom motor execution. So the studies showed that moving the phantom limb during mirror therapy, or imagining moving the phantom limb, is more important, and it yields better outcomes compared to not moving the phantom limb. In fact, in other studies, not moving the phantom limb has been identified as an inhibitor, rather, of treatment, because when not moving the phantom limb, the patient may have an illusion of having three limbs. One, the intact limb; second, the visual reflection in the mirror; and third, the phantom limb that's not moving behind the mirror. So it's quite important to engage phantom motor execution during mirror therapy. The third important component that we noted was complex movements of distal joints. So we've seen that complex movements of distal joints are more effective than performing those simple movements in one plane. So the idea here is to engage in functional tasks that involve the movements of distal joints. And lastly, in terms of duration, we noted that short repetitive sessions are more effective than longer sessions. So it is worth noting that even though people with amputations do not have a limb, but when performing exercises, they can still feel the missing limb, and even interestingly so, they feel fatigue or tiredness in that limb, and that can aggravate pain if the dosage is a bit too much. But it is quite important to know that if it's too much, that can result in pain. If it's too low, that cannot achieve any efficacy. So we need to provide treatment within a sweet spot where treatment efficacy can be shown, but without aggravating the patient's symptoms. So now that we're done with mirror therapy, let's have a look at graded motor imagery quickly. So we recently conducted a systematic review investigating the efficacy of GMI for reducing phantom limb pain. In that study, the results showed that GMI was more effective than routine physiotherapy immediately after treatment and at 6 months follow-up. However, the certainty of the evidence was downgraded to low due to a small sample size involved in the study and a lack of precision in the treatment effect. Altogether, currently, GMI is promising, but further trials are needed to consolidate its efficacy. A side note, which I believe is relevant, especially for clinicians, is concerning the use of left-right judgments or laterality recognition as part of the graded motor imagery program. We know that imagined movements and mirror therapy have some efficacy when used individually or in combination. But currently, I could not find a study confirming the efficacy of left-right judgments for reducing phantom limb pain, nor confirming its role in the entire GMI program. For some time, it was believed that a delayed response time during left-right judgments is due to phantom limb pain, and retraining left-right judgments will improve pain. However, a recent study highlighted here revealed that this is not the case. So in this study, the results showed that the response time between amputees with phantom limb pain and those without phantom limb pain was similar and significantly higher compared to healthy controls with limbs. So altogether, this results shed some light and indicate that a delayed response is not an artifact of having phantom limb pain, but rather an active artifact of having an amputation. So this casts some doubt into the relevance of using left-right judgments in the management of phantom limb pain, but I'd be interested to hear from the clinicians as to whether this component has proven to be effective in clinical practice or not. So in consideration of that, some of the clinicians that I've interacted with have shown that instead of using left-right judgments as a foundational stage of the GMI program, they rather start with imagined movements where a patient struggles to move the phantom limb pain, or in a case whereby the phantom limb feels stuck, and then they progress towards phantom motor execution through the use of mirror therapy. And so far, that has shown great effect. So it might be something worth trying in your practice. Another treatment, as we conclude this section on treatments, is virtual or augmented reality. So a recently published systematic review investigated the efficacy of virtual reality systems in reducing phantom limb pain. So this study included 15 studies, and 14 out of these 15 studies reported pain reduction after a single session. And the addition of vibrotactile stimuli resulted in further improvements in phantom limb pain. So virtual reality has emerged as a new potential treatment for phantom limb pain that circumvents some of the limitations of mirror therapy. So one of the benefits of virtual reality systems is it allows you to engage in functional tasks without being limited to one point as you would with mirror therapy. But the principles of treatment are still similar. So this might be a way forward in terms of the management of phantom limb pain in the future. So other treatments that are worth noting include targeted muscle reinnervation. This is a surgical treatment that involves surgically removing the neuroma, separating the branch of a motor nerve, and joining the distal part to the remaining part of the sensory nerve, as illustrated in this picture. So the idea behind this treatment is to restore targeted function of the sensory nerve and prevent neuroma formation that has been shown to trigger phantom limb pain. So the evidence on this treatment is promising, and this can be used as a preventative strategy for phantom limb pain, but also as a treatment for those who have already been amputated. Lastly, we have peripheral nerve stimulation techniques that are showing some benefit as well, particularly in patients experiencing early post-amputation phantom limb pain. The evidence in this area is still preliminary at this stage. Therefore, further trials are needed to better inform us about the role of peripheral nerve stimulation in the management of phantom limb pain. So as mentioned, there are over 37 treatments that are used for managing phantom limb pain. However, given the limited time that we have, I focused on only those that have shown great efficacy so far. So as we move towards concluding this presentation, let's have a look at how we could better manage associated outcomes. So phantom limb pain, like any other type of pain, is a biopsychosocial construct that is modulated by thoughts, feelings, and behavior. As mentioned previously, phantom limb pain is associated with catastrophizing, depression, sleep deprivation, substance abuse, and a sedentary lifestyle. These thoughts, feelings, and behaviors can directly influence each other and phantom limb pain, therefore resulting in an unending vicious cycle. Therefore, it is important for us to employ strategies that directly target phantom limb pain and each of these components. And the best way to do it is to do it through an interdisciplinary pain team that works collaboratively to identify these factors as well as to manage them. And the idea behind this is by managing each of these components, we will be in a position to better deal with phantom limb pain, therefore breaking the vicious cycle that we tend to see in clinical practice. As I conclude my presentation, we will end off with patient preferences as well as the important role in the rehabilitation of individuals with amputations, particularly those with phantom limb pain. Patient-centered care recognizes the patient as an integral member of the healthcare team involved in decision-making. There is evidence showing that patient-centered care improves treatment adherence, health outcomes, satisfaction with treatment, and also it prevents a mismatch in post-surgical priorities between patients and healthcare providers. More often as clinicians, we have our own biases, mainly due to areas of interest. For example, I am a clinician researcher that's interested in post-amputation syndromes. So when I'm interacting with people with amputations, more often I will assume that they need help with post-amputation pain. And having conducted this study here, I realized that this might not always be the case. The patient preferences, they differ from patient to patient, depending on the stage of life or life circumstances that they may be experiencing at that particular point in time. And the results of this study prove exactly what I'm sharing with you now. So we conducted this study with the aim of identifying care priorities for individuals with lower limb amputations. In this study, we used a Delphi approach with a qualitative component to it. And the analysis of data generated 3 themes. So we saw that preoperatively, the participants prioritized having access to information and planning support. So this is quite important, particularly for patients that are booked for elective amputations. It could be important to provide them with information about how things will be in theater and how life could potentially look like post-operatively. And this, they said, it helps them with planning support, especially in areas that they could potentially struggle in after amputation. Whereas early post-operatively, the participants prioritize their mental health and psychological and spiritual well-being. We tend to see higher rates of depression and anxiety and psychological stress immediately after amputation, up to 6 months or even longer. So it is during this period that it is critical for us to provide mental health support and administer treatment that may help patients in this regard. Whereas in the long term, the participants mentioned that they wanted to live a functional and normal life with respect and dignity like everyone else. So in this case, having prepared them for life after amputation and having helped them with mental health and psychological and spiritual well-being, a little bit later, usually a year thereafter, they just want to be integrated or incorporated into their society and live a functional and normal life with respect and dignity like everyone else. So these findings were quite surprising for me, but I should mention that they may differ based on the context in which these patients live. So this study was conducted in Cape Town, South Africa, so the patient priorities may differ depending on where the patient are and what the circumstances are. So these results should be interpreted with caution. As I conclude, so here are the key considerations as I present them in a summary. We've presented that phantom limb pain is common. Roughly 9 out of 10 people will experience phantom limb pain in their lifetime. And implementing patient follow-up strategies may help us to identify and provide timely care to patients who have a late onset of phantom limb pain. So these are the patients that we get to lose within the healthcare system, because as soon as they are discharged, roughly within 2 weeks after amputation, it is difficult to track them down. And once they have the late onset of phantom limb pain, they are usually out of the healthcare system by then. Therefore, it is important for us to implement strategies of tracking these patients down so that we can give them timely care once they start experiencing this problem. Secondly, we've identified that phantom limb pain has a significant impact on the biopsychosocial aspects of pain. Therefore, an interdisciplinary pain team is necessary for providing holistic care. Thirdly, we've seen that based on the mechanisms underlying phantom limb pain at different time points, the clinical presentation can vary across patients depending on many factors. Therefore, treatment should be tailored to each specific patient based on the outcomes of assessment. Another point here is we've seen that treatments prioritizing sensory and motor training are currently more effective for reducing phantom limb pain. And as for pharmacological treatments, we've seen that the evidence for their efficacy currently is inconclusive. Therefore, further trials are needed. And then, as we were concluding, we've seen that identifying patient care priorities has several benefits. It's patient-centered, and it also can lead to targeted care depending on the priorities the patient has at a particular point in time. And with that, I would like to thank you for your attention and your time. I am more than happy to take any questions that you may have with this time that we have. Thank you.
All right, wonderful. Thank you so much for that talk. And I see we just put up the other screen. So what I'd like to ask everyone in the room to do is to please turn around so that we're not speaking to the back of your heads. No, go ahead, for the whole Q&A, we're going to turn around and face the camera, if you don't mind. And then, so any questions? Any questions? Or just awkward silence? Anyone online? Nothing? Okay. This is kind of, oh, we got one. Okay. Wait, you gotta go here.
With phantom limb pain, you alluded to some studies with different age groups and so forth. And I haven't had a chance to look at those studies yet, but I'm wondering if there were any significant findings that differentiated between men and women, or people that come from different social backgrounds in terms of status, wealth, etc.
Thank you for your question. Currently, as far as I'm concerned, I haven't seen any study that has conducted a subgroup analysis based on sex, looking at males versus female. In terms of socio-demographic status, in the systematic review that we conducted recently, we looked at the prevalence. We compared the prevalence estimates of phantom limb pain between studies conducted in developing countries versus developed countries. So we found it quite interesting that the prevalence estimates were higher in developed countries. But having looked at the literature, we identified that one of the key reasons was because there was just limited literature concerning the prevalence of phantom limb pain in developed countries. Therefore, we cannot definitively conclude whether socioeconomic background may have any impact on the onset or the longevity of phantom limb pain or not. But this is a key consideration and definitely something worth exploring in the near future.
Hi, this is definitely more of a comment and an offer should you choose to maybe someday want to chat. My name is Michael Falcon. I'm an occupational therapist and assistant professor in an OTD program. I'm also an upper extremity amputee. I also happen to be one of the first individuals in the United States to receive TMR out here in California. I was also involved in the first 3 research projects out at RIC for prosthetics in TMR and pattern recognition. So this has been my life, and it's awesome that you are doing the research. I have no interest in doing the research, but should you ever want to chat, Romy knows me well, so she can connect us.
Awesome. Thanks, Michael, for that. Romy is my beloved supervisor and colleague that I worked with for over 10 years in Cape Town. So I'll reach out to her, and then you and I can start having conversations around this phenomenon. Thanks for reaching out.
Thank you very much. I'm a physical therapist, and I wanted to know, are there any studies on preventing phantom limb pain or reducing the risk of developing it in the first place? Like personally, I'm thinking if I was put on that situation, I'd start mirror therapy immediately. That's my gut feeling, but I don't know if there's any studies on prevention.
Yes, indeed, that's where the focus has been in the past few years. So mirror therapy still comes out as one of the preferred preventative strategies for mirror therapy. Currently, there's a study that was published a couple of months ago looking at the efficacy of mirror therapy in reducing phantom limb pain. So what they did is they provided mirror therapy pre-operatively for patients who were scheduled for an amputation surgery. And that showed a decrease in incidence of phantom limb pain in that patient group compared to patients who didn't receive mirror therapy. The evidence is still quite new, so further studies are required to confirm this, but this is certainly something that's positive. So another treatment that's being used as a preventative strategy is targeted muscle reinnervation and RPNI procedures, as Michael has already mentioned. These surgical treatments can be used as a preventative strategy perioperatively, but they can also be used as a treatment for amputees who've already been amputated. So the focus right at the moment is preventing phantom limb pain and also treating it in patients that we missed. So yeah, there is some emerging evidence in that area.
I've seen some older research on phantom limb pain that indicated that people who lost their limbs in ways that were particularly painful or traumatic were seemed to be more likely to develop phantom limb pain later on, whereas there was some indication in that early research that people who had a limb amputated after being sedated and without a lot of prior pain seemed less likely to develop phantom limb pain. But I'm curious if that is held up or if that's changed very significantly.
Oh yes, absolutely. So persisting preoperative pain still remains an important predictor for phantom limb pain. In fact, in the systematic review that I presented earlier, that was conducted by myself and my team, we identified a strong correlation between persisting preoperative pain and phantom limb pain. So the rationale behind that is centered around central sensitization. The argument is patients who experience persisting operative pain undergo maladaptive central sensitization prior to undergoing an amputation. In that, even after amputation, they'll still experience the upregulation of the pain that they experienced prior to undergoing an amputation. And we found it quite interesting that in another study, we saw similar characteristics of pain that patients had before amputation and the phantom limb pain that they were experiencing. For example, if patients had a high pain severity pre-amputation, they also reported high pain severity after amputation. And also, if they experienced burning type of pain preoperatively, they also experienced phantom limb pain with burning characteristics, so on and so forth. So that is a link that we have seen so far, but mechanistic studies are still required to confirm this possible causal relationship between pre-amputation pain and phantom limb pain. And also, just to add to that, with recent studies, we've seen that patients with traumatic amputation, even though they experience phantom limb pain, the pain severity tends to be significantly lower compared to those who were exposed to pain before amputation. So there might be something of interest in that area.
Question from the online community here. We're asking if there was any differences in prevalence of phantom limb pain with para-athletes compared to the general population. And then a follow-up question with that was also, is there any trials out there that look at using psilocybin or hallucinogens to address phantom limb pain?
Unfortunately, I cannot answer that question. I haven't seen any literature looking at different types of group in terms of athletes. And in terms of the treatments that you mentioned, I'm not aware of any literature in that area. But I should say that I am a physiotherapist by background, so my work tends to focus around non-pharmacological treatments that focus on functional exercises more than anything. There might be some evidence in that area, but nothing that I'm aware of, unfortunately.
Okay, thank you. I think we have time for one more.
Thank you very much for your time and for your talk and for the great work that you're doing. You had mentioned during your presentation the specific protocol for the mirror box therapy, and you had mentioned that it's more effective when you have the individual performing tasks that require distal segment precision, so fine motor tasks. And I don't know, maybe this is not available yet in the literature, but since meaning in the context of the experience is also quite important, do you know if tasks, fine motor tasks that involve something of greater sentiment or meaning are more or equally useful in terms of the effectiveness of the mirror box therapy?
That's a great question, a question that we are currently investigating at the moment. But that is one of the hypotheses that we have, that engaging fine motor skills, especially functional ones, might have a sentimental meaning or value to the patient. Another hypothesis that we have is they might lead to, I would say, a wider activation of cortical networks compared to simple gross motor movements. So it's a hypothesis at this stage, something that we are currently looking into. So hopefully we will have answers in the near future.
All right, thank you again for your wonderful talk. Do you want to give them another round of applause?
Thank you, everyone.
And we really do wish that you could have been here, hopefully sometime in the future. Okay.